Okay, welcome to this meeting of the Health Overview and Scrutiny Committee. This meeting is being broadcast live to the public via YouTube and will be available for viewing on YouTube after the meeting. So please turn your microphone on when speaking and turn it off when you have finished. So there are no changes to the committee membership this year, so welcome back to you all. And I'd also like to welcome back the Cabinet Lead Member for Health, Mrs. Louise Richardson. So, as this is the first meeting after the annual council meeting, the first item on the agenda is appointment of chairman. And Mr. Jonathan Morgan was nominated as chairman-elect at the council meeting on the 15th of May. Could I have a proposer and seconder that Mr. Morgan be appointed as chair, please? Thank you, Mr. Harrison, and Mrs. Seaton seconding. Everybody happy with that proposal? Thank you very much. I will hand over to Mr. Morgan for the rest of the meeting.
Thank you very much, Ewan. And we go on to item 2, which is the appointment of the vice chairman. We have a nomination, which I think is Mrs. Brenda Seaton. So I can propose Mr. Seaton. Can I have a seconder? Should we have Ross this time? And then he feels as if he's wanted and needed. There we go. Okay, right. So all of those in favour? All of those in favour? Thank you very much. That's great. Right. So we're on to item 3, which is minutes of the meeting. Welcome, by the way, Mr. Seaton.
Thank you.
Thank you.
Likewise.
So item 3, which is minutes of the meeting held on the 6th of March. Can I propose that those are taken as read and confirmed and signed? All agreed? Excellent. Thank you. Item 4, question time. We haven't received any questions from the public. Item 5, questions asked by members under Standing Order 7375. We have received no questions from members. Item 6, to advise any other items which the chair has decided to take as urgent elsewhere on the item. There are no items to be taken as urgent. Item 7, declarations of interest. Are there any declarations of interest? Mrs. Newton, for once, there aren't any NHS items, so you don't need, but you don't need to, because there are no NHS items. No, I was going to say this is a novel meeting. I think this is the first time that we've had nobody from the NHS. Are there any other declarations of interest that anyone wishes to raise? I think that's the first time we've had absolutely no declarations of interest. Good grief. Right. Okay. So we're on to item 8, which is the declarations of party whip. Are there any declarations? Don't think there are. Are there? No. Everyone's whipless. Then on to item 9, presentation of petitions under Standing Order 35. I haven't received any petitions, so we're on to item 10. There we go. We're on to, we have 2 items at the meeting today. The first item deals with probation health trainer service, and we have here Sally Valence. Welcome, Sally, and also Mike Sandys. So Sally is head of service public health, is going to present or answer any questions, and Mike Sandys is here to if there are any words additionally to say. So as always with these agendas, we'll take everything as read. We all of us have read the papers. Thank you very much. So any questions that come up on the papers, then we'll go straight into those. However, Sally, if there's anything that you want to say to draw attention to any particular items within the report, absolutely, please do take a couple of minutes to do that. Otherwise, we'll go straight into questions from members on the report. So over to you, Sally.
Thanks. Hello, everybody. So just, briefly to set out a few key points, as you kindly said. The Public Health Service currently hold a contract with a provider called Ingeus to offer this service, the probation health trainer service. It involves supporting people on release from prison, assisting with things like accessing GPs, referrals to mental health support services or benefits advice agencies. And they're in contract until 31st of March next year. We've carried out a review of this service to look at the provision that's in place. That's found a number of strengths with the service, but also some limitations that are covered within the report. And Public Health also have an MTFS savings target at the moment of 90,000 that's due by the 1st of April of next year. So we're working within that context of the savings agenda. We also have an issue at the moment with NHS England have commissioned a Reconnect service. We're looking into that locally. We understand it's provided by LPT, and that looks to offer continuity of health provision for people as they leave prison. So some potential overlap or duplication of provision there. So that's something we're examining at the moment. The proposal that you have in the report today is for us to decommission the service at the end of the 31st of March. And that's something that we're out engaging on at the moment with targeted groups of people. So we're specifically engaging with the probation service at the moment, with Ingeus, our service provider, and with people using the service to understand the impact that that proposal might have on them. And as I've said, we're also looking to talk to Reconnect, that new service that's around, to better understand that offer at the moment. So we're gathering all of that information together, and then we'll be coming to Cabinet, and we're aiming for the September Cabinet to bring forward a proposal for a final decision at that point. So the report is brought to you today to engage with you and seek to answer any questions, and for you to ask any questions of us as part of that work. Thank you.
Thank you, Sally. Mike, are there any other points you want to make?
Yeah, just to Sally, could you remind me, so it's coming here not as part of formal consultation, but as part of a light touch engagement. I just wonder if it's worthwhile just saying why it's an engagement and not full consultation.
Yep, thank you. The engagement is in order to inform the report to Cabinet. So the report to Cabinet needs to set out the impact of any proposals. So in order to do that, we're engaging with parties that might be impacted by those proposals. That's why it's a targeted engagement. We're not under a duty to undertake a full public consultation with this one. This is about informing Cabinet so that they can make a robust decision on that basis.
Okay, thank you very much. So we've got 4 hands up at the moment. So I've got Brenda first, followed by Betty, followed by Dan, followed by Ross. Mike, you're just going to hold your fire for a bit? Yeah. Okay, in which case we'll go with the 4. So Brenda first.
Thank you very much, Chair. My question is to do with the workforce. This is the first time I've heard Ingeus, is it? Or yeah. And how many? Who are they actually? Are they NHS trained staff? Have they got training? And what will happen to them once it's May 25, isn't it? That it will cease maybe to exist. Thank you.
Thank you. I'm afraid I don't have the exact number of staff impacted. That's something we can ensure we will have behind the scenes, but I don't have that figure today, but I can come back. It would be up to the provider to look at the impact of that. So it depends partly on their own policies and their employment contracts and processes within their organisation. But it would seem likely that a withdrawal of funding may well result in some redundancies. So that would be something that provider would need to account for. But I think we have to be prepared for the prospect of redundancies as a result.
Redundancies in the provider, though, not within the LCC workforce. It's the same as anybody who doesn't win a contract, or
exactly.
If you decommission, that will be where the impact would be felt.
Thank you for that. And because it's a joint venture between us and the city, so do you know what the city is proposing?
Thank you. Yes, the city are going through their own processes and their own governance. We understand they're also considering similar approaches, but obviously that's subject to their governance. So we are in constant liaison with the city and ensuring that we're working sort of hand in hand with that because of the joint commissioning arrangements there, or the aligned commissioning arrangements. And apologies, I just have had a note pop up here saying there are 3 staff involved. So just a feedback on that point.
Three staff, so that's not a shocking amount, and but for 167,500, and there's 3 staff combined, city and
I believe that's the county figure.
That's the
so
count
that's our
figure.
figure, yeah.
And could I just, for clarification here, the 40 individuals and the 44 individuals, is that city, county, or both together?
Sorry, what was the?
Sorry, the
numbers of individuals?
40 individuals had personal help. So saying that it only reached 44 individuals. No, I can't find where it is now. So I didn't know whether that figure was combined.
Apologies. Yes, that's a county figure. So those are the figures for our allocation. Yeah.
Okay. Thank you.
Thanks.
Thank you very much. Before I move on to Betty, can I just ask, because obviously this is a sort of joint programme, and therefore any announcements through county are going to be flagged probably at city as well. Have city actually talked about this in any of their committees or processes publicly up to now?
I'm not aware of that happening, so I don't believe that has occurred. Certainly, we're in regular contact with officers to inform them of what we're doing. Obviously, we're entitled to take our own route as a local authority, but we obviously have worked hard to align the contract so far and wouldn't want to deviate from that hard work and that partnership work. But I'm not aware of any committees formally that they've been to.
Thank you very much. Betty.
For the report. I just was reading through it very carefully, and I looked at about the fact that the council has no statutory duty to provide services for people who are released from prisons, and also the mortality rate for prisoners is 50% higher than the rest of the population. I mean, my worry is if there's no services there, what can we do in terms of preventing reoffending? How can we help people to actually get on that straight and narrow path and get a job, keep a job? It's a support issue more than anything, but I think it's a bit of a concern that they're dropped out in the community, and that seems to be that basically. Thank you, Chair.
We'll do a double act on this one. So it was something that we were discussing before. And I guess from my point of view, I don't know what you'd say, Sally, is, the health status of offenders is awful. And the paper sets out, the life expectancy figures or whatever is really bad. If you look at, sounds horrible, but if you look at kind of what kills them, it's issues around substance misuse, drug overdose, suicide. And there are services that within public health we provide that do address those issues. So I guess this service is a broader support issue. Not that it's not unworthwhile to kind of build health resilience, if you like, in people, but given the capacity and the take-up and the money we spend on it, is it the best use of our resources? For me, and I don't want to get into talking about the homelessness contract again, but it is a parallel where we said, look, we've got this specialist broad support model, but then we've got more specific services that we'd still continue to provide. If we can't do this bit, we need to make certain that the specialist stuff, the real, take the substance misuse one, has got an offer that is directed towards, make certain that offenders or the homeless can tap into it. So the real drivers of why do people die early, we're still hopefully supporting. But what we're losing is that kind of broader strength-based health resilience kind of model, which if I had the money would be great, but if you had to choose, I'll keep this and not this. I don't know if you wanted to add to that.
Can just be clear, this is not the same as probation service. I mean, the probation service is completely separate. This is a completely different issue. Is that right?
Worries. It is a separate service. It does support the probation service, and certainly they're one of the parties that we're wanting to engage with and are generally positive about the support that they receive from this and are concerned at the loss of the service. So there's certainly a relationship there between the probation service and the probation health trainer service, and we'd want there to be, because that's the purpose really. So yes, they are separate services, but there is the relationship between the two, and I think that's where some of the impact perhaps may be felt as well, which obviously, the probation service may want to kind of reflect on that as well.
again, not set up as a double act, and it's getting into kind of some of the engagement responses that we're still receiving. But I think there is a debate for me about what the probation service used to do and the capacity that that service had in terms of dealing with those kind of broader health issues, health literacy, etc., which the probation service hasn't got anymore. And we've filled that hole by commissioning this service. Now, does that make it our responsibility to commission it, or do we need to have a conversation back with the probation service to go, this is that kind of holistic model of support you used to provide, but you haven't got it there. So I think there is an issue there. Again, parallels with homelessness, you could argue the toss about whose responsibility is it to fill that hole. We've done this. If Reconnect is coming through the NHS, that means they can provide that support, then at least there is that broader holistic support available to offenders whilst we concentrate on the more total public health bits like substance misuse.
I've got someone that actually works with prisoner welfare and some family member, and the issue really is when they first come out, there's serious problems because there's no infrastructure really to support them to prevent that reoffending. Not sure what one can do about it, but I personally think that if there was more help out there, maybe there'd be fewer reoffenders. I don't know, but it's just a comment. Thank you.
Thank you, Betty. Dan.
Thank you, Mr. Chairman. It's a very succinct report. It outlines quite clearly there is a need to save 90,000. This isn't a statutory obligation. The MTS, I think, for the 4 year is running about 80 million plus deficit. So we have to really stick to our knitting and know what we're doing. When I looked at some numbers, I mean, the total number of 40 into the amount worked out about £8,815 per person. So you have to also work out, is it value for money, what we're actually doing? I know there's comments about, well, hang on, people coming out of prison. In a different job role 3 years ago, I spoke to the Chief Constable and the Governor of the Leicester Prison, went through it all and came up with a package to try and seek support in. Problem is, 60 or 80 pounds in your hand and you walk away, that's it. But if they had, my vision was a large warehouse and like shepherd cabins, so they've got an address, now they can start to claim benefit. And if they're there on a 6-month lease, they've got 6 months with accommodation to get a job. And it was positive. Otherwise, it's all palliative. It's just around the edges, and it's not really jumping in and saying, this is the problem. Because they've got nowhere to go, what are they going to do? And we all know the story end on that. So I think for value for money, the necessity for looking after our own budgets, where we are obliged to provide services, we need to be able to keep our eye on that pot and not, sadly, it'd be lovely if we could, but we're not in those days. Obviously, originally, we were in more money plentiful, probably when this was a project idea going forward. But no, we're no longer in that world, and we've just got to be sensible, really. So I'm happy to propose the thought process on this, and review the existing provision proposal for decommissioning. So, Mr. Chairman, I would support that project of decommissioning if it's appropriate within the framework of this meeting. Thank you.
Okay, thank you very much. I think at the moment this paper is just for information rather than actually any decision making on this body. But I think you make an important point also about the differentiation between the bit that we do as an authority, which is purely around the support on health, and actually the wider context, which I know Betty and Mike and Sally have sort of touched on, which is about the probation service and how that does. And I'm very conscious of, you know, I suspect we all have strong views about the support for prisoners after release, but actually the bit we're talking about probably is a very small element of that, and obviously within the remit purely of public health support. So that's you know really the bit that the paper's trying to address. Ross, do you want? Sorry, did you want to come back on Dan's points at all?
Wasn't. I was just checking with Sally that the engagement, it's not like the formal consultation, which would be minuted in the cabinet report, but clearly it would form part of what we then report to cabinet when we go back.
Thanks. I'm sure Ewan will be reducing minute items, sort of summarising what we're talking about. Ross.
Thank you, Chair. Just my understanding, can you just clarify exactly what the personal health plans are consisting of and are? Because there's a couple of themes mentioned in the report, access to benefits, GP registration, but are they seeing a clinician and they're doing, tests, blood work, whatever, and saying these are the sort of things you've got? Is it like a welfare check more than anything? It says signposted services, but what does that actually mean?
Thank you. Yes, this isn't a clinical service, so there aren't any clinical checks being carried out on people through this service. It is that case of sitting down with an individual and understanding what their needs are in terms of accessing services in their community and in terms of health improvement for their own individual health. So that might be that they have something that is troubling them physically health-wise, mentally health-wise, and that they need referrals to their GP to have those checked out, or into mental health agencies to have further support offered. Or it might be that they need some support in claiming benefits, accessing food banks, those sorts of things. So it is understanding with that individual and then signposting and referring on, and sometimes attending those appointments, some of those clinical appointments with them if they require it.
Yeah, thanks. You couldn't resist, could you, Mike? Okay, over to you.
Thank you, Chair. How long has the service been running?
It's been going for a long time. I believe we've had a contract since 2019, but I think it may have been running from prior to that, funded through other organisations. This current contract has been running since 2022.
Okay, thank you. I take the point about the budget being tight and are we getting value for money sort of thing, but I think of the money that we spend, I think the majority of it goes on staff pay. I don't know much about the probation service in general, but I would have thought when you leave prison, some sort of network is there to help you, and this is just one strand of it. Looking at the health aspects of newly released prisoners. I don't know whether the PCC could step in and help in any way. Is a conversation going to be had with them about this? I don't see why not. They may have some money spare. I don't know whether their budget's as strained as ours. It's non-statutory. I get that. I sit at Oby and Wigston, and we're going through this same process as well, looking at non-statutory services. I just think at some point in all our lives, we need help and assistance. Whatever the situation, medical, whatever, we need help and assistance at some point. We're unemployed. And the more we diminish the services, the less assistance for people there is out there. And I think it's sad. I get the reasons behind it. And don't get me wrong, I don't want a 114 notice here. I just think it's sad that we diminish these services. I hope the conversations with the probation service in general produce something that helps. God forbid I or anybody else is in their situation. But clearly it has some effect of the people they speak to. It seems to have some effect with most of the people they deal with. So it's providing a service. So I hope you can have conversations with as many as you can to find something or some other way of helping. Thank you.
Thank you. We haven't picked up specific conversations with the PCC, but I'm very happy to take that on board and take that forward. I agree. The review has shown us that it is a valuable service and that people do appreciate it. So, whilst we have found one or two things that could perhaps do with some improvement, there was definitely positives to the service. So that isn't a reflection on the service. It's a reflection partly, I think, on the pressures we have around savings agendas at the moment, and the fact that we have got other provision, we believe, out there at the moment that can offer that specific support for many of the issues that people are facing. But as I say, that's not a reflection on the service that we're presented with today. Thank you.
And just to come in on that one, actually, I think that's a good question. Again, I'll draw a parallel with homelessness. Don't want to go through that particular routine again, but I suppose for that one, you could argue what started off as a conversation and a proposal around a particular part of funding from public health to the homelessness sector. I know Josh sat behind you and Sally was involved as well. It did trigger a load of conversations about how the system works together in terms of providing support for those at risk of homeless, be it district prevention, housing prevention grant, etc., which we kind of carrying on. Runs the risk of public health then kind of getting involved in everything, but then again, everything has got a public health bent to it. So I think there is a role there. Potentially, I guess I'd argue, I mean, I think probation health trails, again, looking at Adrian behind you, who's in for the next item. We've had that contract forever and a day, and it's probably existed in glorious isolation within public health. So if there is a positive that comes out of not having the money to have a standalone service, if it plugs us into community safety conversations with PCC and others about the breadth of support provided, and we'll be doing our bit of that, you know, in terms of the substance misuse services, and making certain that that whole holistic support has a health bent to it, then that might be an unintended positive consequence out of an unfortunate decommissioning.
Okay, thanks a lot. I think the last question is for Ross in that case.
Thank you, Chair. Just one other thing as well. It says here that most of the authorities that have offered the service in the past have now decommissioned it, and I think there's only one remaining in the East Midlands. Have you looked at what's happened after the other authorities have decommissioned their services? Have there been any major hiccups that have happened, or have most of the people that accessed the service before been able to, you know, gel into other pathways relatively seamlessly?
Thank you. We have checked with a number of authorities. For many, that's happened over a series of years. So they either haven't tracked that information, or it's too historical now to be able to share that information. Anecdotally, some have reported that that things have gone relatively smoothly and that people have accessed other services. Others are still, you know, feeling there is perhaps a gap that they would like to fill if they had the means to do so. So we haven't had concrete evidence from any local authorities that have been able to show that impact. But obviously, I think the other issue with this population is the impact is very complex, and it's really hard to measure whether it's one specific service that has had that impact, or whether it's changes across the whole system. And we've had some of those conversations today, haven't we, about the number of organisations that were involved with these populations. So it's really hard to track the impact as to whether it's a probation health trainer service withdrawal, or whether it's other kind of service withdrawal or changes across the system. So it's a rather long answer to say I don't have anything concrete, I think. Thank you.
Thank you very much. Brenda just reminded me she had one last point she wanted to make.
Thank you, and it's really just for my knowledge. We're talking about 40 individuals here, and I can't compare them. How many prison releases are there in a year? So 40 to take that up, I would say that it's not working well. But then you think of it's only 167,000 for 40 individuals. So obviously, if more people took it up, it would be more costly. So what I'm saying is, for value for money, then I don't think it's working well, and it's not hitting the large population of prison releases out there. So.
Thank you. Just to flag, yes, the 40 was the 22-23 figure. We have now got the 23-24 figure, and that was up to 119. So quite a large increase on that figure. So just to make sure I pointed that out. I don't know, I'm afraid, how that sits within the wider cohort. What sort of fraction of the population that are released from prison each year that's reaching. But yeah, we do know that there are specific referrals for people of concern that are sent through to the service, and that yes, it has been working with 119 over the last year. Thanks.
Okay, thank you very much. Look, we've had plenty of comments on the paper, so thank you very much. And also, I suspect that there's still probably work that you'll put into the paper before it actually appears before Cabinet. I think the point about actually how many of the total prison release population do those figures represent would be interesting, because it would also be interesting in that case for those that don't access it. I'm assuming, as Mike mentioned as well, there are other services that we provide through, for substance abuse and mental health, etc. How many are being accessed by prisoners who have been released through other means? I mean, it would be fascinating to actually know, how porous our systems are for picking up people who actually need them. So lots of points. I appreciate, as ever, and I think Mike and others have mentioned, the budget constraints mean that sometimes we're now looking at things that probably would not have been looked at maybe a few years ago, and obviously that's always with regret. But the important thing is, if we are having to make those decisions, then we do so with an active response to other organisations to make sure that people can still access the services that we do actually provide, and make sure that they're aware that they're there if they need them. So thank you very much, Sally. Okay, we are now moving on to item 11, which is the Public Health Overview and Annual Review. We're joined by our two Deputy Directors, Joshna and Adrian, who have both been flagged already by Mike, so they've been already softly introduced to everyone. So welcome. Three of you can hopefully now give us a good understanding of how the public health. I know when this paper was being discussed a couple of months ago, we thought it would be a good way of being able to actually show the sort of breadth of the public health service through county. There's a huge amount of the budget, as you've discovered through the paper, that is provided nationally. And there are certain things that the team provide, which are national commitments, statutory commitments. But there are also many other things that are there to support the general sort of requirement, which is actually to support the health of the community within the county area. So hopefully we'll have an opportunity to go through some of those things and to actually talk about some of the sort of the breadth of the service that is being offered by public health. So as always, we'll take all the reports as read. Thank you very much for those. Great to read them. Mike, do you want to say just a couple of words to introduce this before we actually go into any questions or debate?
Yeah, thank you. I haven't got too much to add to what you were saying. So I hope it makes sense to the committee. In terms of background, it sounds a bit daft. It's obviously 2013 that we transferred over. In the last 11 years, there's been an awful lot of items that have come to scrutiny on where we've redesigned services, either because of the need to save money or to respond to things. That's always come within the committee. My annual report has come with the committee. The one thing we've never taken is an overview of how as a department are we responding to the public health challenges that we've got. So, and I've put in it, I'd like this to be an annual review because I think we should have started doing this 11 years ago. So I would like this to be a kind of the first of an annual look at what we're doing. There is a hell of a lot in there, and I realised when I started writing it, it's difficult to describe the kind of framework in which to describe public health. So part of me has described it in the paper as the different parts of public health, health improvement, healthcare public health, where we support the NHS, health protection, being those three. Then in terms of discussing the services, I've split them into kind of internally provided services and externally commissioned services, all of which hopefully gives an overview of what we spend our money on, what services are provided, but then I suppose more importantly, how do we more generally respond to the public health challenges that we face. In the appendix, you see I've referenced a couple of things which probably do the detail more justice than I've done in the paper, one of which is our directory of services and the other is our public health departmental strategy, which we launched 2 years ago. So more than happy to take questions on that. If there is any particular good points and compliments, I'd like to introduce myself, Mike Sands, Director of Public Health. If there's any negative comments or things that you're not happy with, I'd like to introduce my two assistant directors, Dr. Joshna Mafji and Mr. Adrian Allen. So there we go. And I'll shut up at that point.
Joshna, Adrian, would you like to say anything else in addition to that? Or are you just looking forward to all the negatives? Okay, well, look, we'll go straight into questions in that case. Can I see the first question, Brenda, and then followed by Ross?
Thank you. My eyesight's not that good, is it, Adrian? Hello, I'm going to start with you, Adrian. Your question, your starter for 10. What is the difference from this to what it was? What's the difference? Been the purpose of gathering all this information together? And what's the outcome? Have you achieved the outcome you wanted?
Yeah, so I guess we've had a strategy now for 2 years. We've always had a service plan each year, and part of the reason for public health moving into local authority was that integration within the wider authority. And I think by pulling this together, it's enabled us to see all of the factors together. So even though we're a relatively small department, the 3 domains of public health, as Mike has alluded to and that's in the paper, are all quite separate in the department. And although we try to matrix work, they're all separate for a reason, because they are very separate things. So by bringing the delivery mechanisms and the results from our delivered services together with our commission services and all the other work that we've done, I think has helped us to identify the next phase almost, and how we move forward and deliver the last 2 to 3 years of our strategy. So kind of bringing it here has enabled us to have the time to think about all of those things together.
Well, if I can chip in as well, depends how far back you go. Year on year, things change incrementally. If I think about how things have changed since we came over from the NHS back in 2013, we talk a little bit in the paper about the service redesign that we've done. Say we've always got a predilection, if that's the right word to use, to bring services in-house where we can. I think we've had various things have come out of that, one of which is, I think, just showing people that they are public health delivered services, and the county council is the public health authority is an important thing to do. Don't get subject to member scrutiny, which is good. And I think we've got loads of different examples about how things have changed over the years, where we deliver a better service that's more responsive to the needs of people in Leicestershire at reduced cost. Talk about smoking cessation in there, third the budget that we had in 2015. What have we done with that? Well, we've played our part in helping delivering, the below national rates of smoking prevalence, lowest in the East Midlands, the biggest fall in smoking prevalence of any of the counties. And I think we've done that all the way through using channel shift and the innovation around that. So again, smoking cessation is a good example, but talking about kind of delivery of sexually transmitted infection kind of testing online. People can request a test and it gets sent to them in the post. There's just been so much, and again, I won't take the compliment for this one. The team over the years have just done a fantastic job of recommissioning stuff or bringing services in-house and delivering a much better service at reduced cost. We've lost services along the way, because we just heard about probation health trainers, because there's always going to be the grant's been going up by like 1.5% a year, and inflation's obviously been more than that, wage pressure or otherwise. But in terms of what we deliver for the money, I think it's excellent. Please.
Thanks. I'd echo Mike's comments there. I think it's really important to bring this review forward at this time, especially when we're looking at budgets across LCC, and bearing in mind we're grant funded rather than the general fund. So I personally think it's really highlights the amount of work that's done by quite a few people on a very small budget, and a number of the initiatives that have been put in recently have been picked up nationally and regionally as really good initiatives and being taken on by others. So I would really want to say, put on record my thanks to the team, because they are a small team, but you can see how much of a breadth of services that they're producing.
Ross, followed by Dan.
Thank you, Chair. So my question sort of continues Louise's theme as well, and I'm always taken aback by the breadth of services that the department offers. Obviously, being grant funded as well, as with any department at the county council, though, you have to make sure that you're getting value for money. How, taking an overview of everything that you presented, I'm curious, how does the department decide what is value for money? How can you compare, say, a weight loss service to a local area coordinator or drug misuse in figuring out where we're going to spend the pennies that we do have?
That's a good.
just to extend it as well, because I feel like a lot of the outcomes of public health we're not necessarily going to know about. I mean, the previous officer mentioned that as well. If you go into a school and you do a healthy eating club, okay, you can measure their weight, but they're not going to drop a stone in a couple of weeks, are they? You know, it's going to be lifestyle changes that's going to be tracked over a lifetime. If you stop smoking, you're not going to suddenly prevent cancer after a week. Again, it's going to be cancer rates decrease over a lifetime. So how do we evaluate what success we've had and the money that we put in when comparing different services?
I'll go first, and I'll bring both Joshua and Adrian, I think, to this one. So how would we start? I'd like to think, well, there will be an evidence base, probably more so in our department than any others, not knocking other departments, but such as the nature of health research. If you look to why do we do what we do, weight management service, the smoking cessation service, there'll be an evidence base behind it, largely in the form of NICE guidance, National Institute for Clinical Excellence guidance. So, you know, if you take LACS, even then there will be NICE guidance around community asset-based approaches to health improvement, you know, and that'll be backed up by evidence, sometimes from national reviews. Quite a lot of the evidence, particularly around LACS, is ones where we've been the pilot site that have inputted into it. So when we get into the commissioning, however you describe it, small C, big C, there will be an evidence base there. We back that up then by doing our needs assessment work that looks at the need within Leicestershire. Is it a big issue for us? And then we deliver those services, and whether it's a commissioned externally services or whether we deliver it in-house, we've got our kind of KPIs and our dashboards that monitor our performance. Trying to prove an outcome in the end, take weight management, take smoking cessation. How much of the difference in smoking prevalence is down to our service? How much of that is down to other issues, taxation or whatever, is a fair question. One I can't answer totally. You know, I mean, you can have a go, but you know, you can probably never tell. What you can really do is actually, were we delivering an evidence-based process? Were we doing everything that we should do? Yes. Oh, and look at the outcome. We must have been doing something right. So there's commissioning, there's evidence base, there's good performance monitoring. In terms of prioritisation, that's probably the bit you're going to come in, isn't it? So one of the things we've done ever since we started, and we just refreshed this, is got our own little departmental matrix where, if you like, we've got a number of things that go into a scorecard. This service, is there an evidence base? Is it strong? How many people does it reach out to? You know, is it small, medium or large? Does it have an impact on those people, small, medium, and large? And we end up with a score, and this is the joke, it comes to about 240, doesn't it? And we use that in our own prioritisation. In fact, I'll take probation and health traders as an example. That one for years has been scoring fairly low in terms of its impact because of the small numbers and the difference it makes. So if we're making hard budget decisions about what we can afford within the envelope of the public health budget, probably it's one of the ones where you were never going to prioritise it above smoking cessation. The other bit to build into that, which comes on to a bit about grant conditions, is how do you decide what's important? And I'll leave local area coordination out of it because that's almost a kind of more philosophical thing about how do you improve health. But clearly you would prioritise making certain that you're doing enough on the big hitters, the big killers, be it smoking, physical activity, obesity, weight management. Said in my annual report last year, the government's kind of emerging, obviously paused for a bit, major condition strategy will determine those priorities, musculoskeletal illness being one of them. And what we know about what do people die of and the effect of lifestyle behaviours, and that would be another one. So again, you know, take smoking cessation. It's not an individual statutory service. Would we, you know, would you ever say as a director of public health, well, I don't think we should be doing anything on, oh, but it's still the single biggest cause of preventable ill health and death? No, you'd be mad to. So it's probably a long-winded answer, which is supposed from the point of view of our service prioritisation, I'd like to think it's shot through with evidence, needs assessment, decent commissioning, and then robust evaluation and monitoring. In the context of how do we decide to how we do this bit, then that's about understanding your population health needs through the annual report, through our dashboards, and through evidence of what works at starting point. So, Adrian, Josh, now I don't know if you want to add to that.
Yeah, I guess there's a few other things. We benchmark. So we benchmark all of our services against other authorities, like authorities, but also other areas of the UK, taking into consideration our low level of funding per head of population, etc. So we model all of that. The other thing we do, which I guess is quite unique to us as a department, as whereas other departments don't do it, is that we do health impact assessments, and we do those annually on our delivered services. So we're always looking to make sure that what we set out to design and deliver is actually doing what it was what we set out to do. And quite often that has changed how we deliver services. Something like smoking cessation. There's vulnerable groups that we target specifically. Through the last health impact assessment that we did, we found that actually we weren't accessing in quite the way that we intended to. So that's brought about change as well. So we're always constantly evaluating the services to make sure that they're impacting in the way that they were designed to impact.
Just going to add to that in terms of the benchmarking with other authorities as well. One of the key things that we can do is also benchmark against spending versus outcomes. So we can also compare how we are performing with other authorities as well. So we do use all of the tools that are available to us to sort of do that comparison.
Back to me, because I've just remembered one other thing. So I suppose that is about how do we think about prioritising our services. The other bit, coming back to what's in the paper, is the mix of things we can do, and actually spending the grant and delivering services is just one thing. And I guess, I don't know, in my, if I was reflecting on the last 10 years, when we first came in, remember that I'm looking at Adrian because it was before your time, Josh, and it was a conversation we had early on, which is, first thing we've got to do when we come over to the council is embed ourselves as being credible commissioners of services. Because we've got this grant, let's spend it wisely. So, and I suppose we've trotted out what we do about that over time. And coming back to what makes a difference to health, we've probably had that discussion within the department, which is beginning to carry on doing good commissioning and delivery of services, but recognising we probably need to move more into the kind of the partnership space, as they say, and that kind of health, the health and all policies kind of, affecting healthy policy. So over the last few years, we've probably put more effort into that kind of health and all policies approach, working with environment and transport, working on things around air quality, getting into some of the broader partnership work. And I'm looking at Josh doing this one around community safety. So making certain we're having that input, because the grant is one way of doing it. But actually, if you were to look longer term, we'd probably need to make certain we put the effort into the developing healthy public policy wherever that happens. So again, the question about probation health trainers, the real benefit would be actually driving a conversation with the probation service about how do you make that whole thing healthy, rather than just focusing on the 167 grand that's spent on a bit. So that's probably the other bit, coming back to Mr. Seaton's question, that's changed over the years, is balancing the needs of being a service deliverer to then going on how do we demonstrate that we're good at partnership work and we're having effect on public policy too.
Sorry, I'd just like to come back to Ross's point about, how do we see, because it's long term, public health is long term before you see quite a lot of the positives coming through. And I think that's something that sometimes is a challenge when we're looking at budgets and everything is within 2 or 3 years. But without the prevention side and without the public health, it has a very big knock on to other services further down the line. So it's really important that we provide these services.
Excellent. Ross, did you want to have any other points to come back on, or are you more than happy? More than happy. Excellent. Okay, Dan, then Mike.
Thank you, Mr. Chairman. Yes, I'd like to say what a comprehensive report this is. It's a fantastic report. I can see the work that's gone into it. Just 13 below the average. So it's hitting those balls now and trying to catch up. Obviously, there's a lot of good stuff here. But it's, it's about how we can improve. I know you do a lot of benchmarking everybody else. You've got to always remember, the more you put in the boiler, the more steam you'll get up and the way you'll go. So you've got to have one eye on that, but you've clearly got to be looking ahead how we can improve and advance ourselves. And Mike's outlined some of that in the last few minutes. The bit I want to talk about, I ask regular, Mike knows exactly what I'm going to talk about. Air quality. There's a little note here, we jointly chair the Air Quality and Health Partnership and Environment. It is a problem because I know the districts operate this. If it was under our authority, it would be different. They actually provide planning consent, which is more harems, and there's a conflict of interest all the time. I even know where they've turned down or turned off monitors. So I know the thing isn't good and it isn't how it should be. And there's one or two of them put themselves forward as great knowledgeable people in all of this. But it is something that's really dramatically important as a killer. It does destroy health. The particulate matter is absolutely frightening. And I've said it before, so I say it again. It's not just out the exhaust at the back, it's the brakes. You get all that stuff on the brakes, you can see. And then obviously tyres are another element that they sort of have to contend with. Now we are moving towards electric, but who knows how long that will take, and the bumps on the road it's a good way to describe it. Who knows what's going to happen, but it is a problem, and we've got to think of schools, how many vehicles turn up and dropping children off, or turn up early and the cars are on in the winter time or on in the summer because they won't cooling down. So I mean that there is elements, and it's not an easy one to grasp, but it is very, very serious. And PM 2.5 particulate is so tiny, it's a strand of your hair. But when you look at the particulate of PM 2.5, it's half a strand. But your brain has lots of the one strand, hair strand quality vessels, and this is where the particulate gets in, and the scientists are now declaring in the NHS that they believe it's one of the main causes of vascular dementia. So there are things, and it's just, if I can keep nodding and saying, what about this? It's maybe going to encourage how we could improve where we're going, because I don't think there's anywhere near enough surveillance and monitoring of it within the districts. Thank you.
I go first on this one. Yeah, thank you. I mean, air quality is it's a classic of sort of public health, isn't it? You know, is there a service that we can commission within the grant that would make air quality better? No. Is it a big part of our work, certainly Jenna Parton within our department? Yes, it is. You know, there is the two-tier aspects, and again, we've been over this before in terms of air quality management areas and that kind of point source of pollution being the responsibility of district councils. What's the public health bit? Working with them to understand sort of some of the monitoring things, where we worked with them to put extra monitors in the ones that you know the name of, and I've forgotten what they are, but as opposed to the usual diffusion monitors. And then the other bit, I suppose, is understanding the Leicestershire context. I know Jenna said the other day, I think we've fallen into sort of fourth quintile of the 5 in terms of performance against our kind of comparator authorities. Why is that? Some of that is understanding, of course, Leicestershire is unique, middle of the country, and it's makes for a great place, but it causes its own challenges with air pollution, because it's not just about road traffic and the M1 and Leicester City being in the middle of that bit, but also agricultural blow off. There's the industry, the quarrying, you've got the airport. If you were to do a map of all the different sources of air pollution that crops up in the national guidance, you go, oh, Leicestershire's got a bit of that. So there is a plethora of partnership working with people to understand what is it that we could do, working through districts, national highways, East Midlands Airport, to try and reduce that pollution. So it's a classic of it being a big public health issue, albeit there's nothing much direct as a public health department that we can do. We need to work through other people. Again, coming back to how we've changed in the last few years, I think we've got those relationships and that partnership working, not at a better level. I think there's just more of it going on. And again, I could take credit for it, but really it's down to these two guys and Jenna and colleagues in the department that have done that. So remains a big issue, not an easy one to sort out.
Excellent. The only point I'll come back down, it's really worth putting into public context as well. You know, the air we breathe is actually cleaner than it has been for hundreds of years, thanks to the fact that we aren't burning coal and wood in the way that we have been for centuries. So, understanding air pollution is still incredibly important. We can still forever crack down and get it a lot lower. But literally every single day, the air that we breathe actually gets cleaner and cleaner as we actually cut out more and more of the fossil fuels that otherwise we've been burning for centuries. So, in global terms, absolutely, air quality is still an issue, but it is always worth coming back to. Actually, the air we breathe is substantially cleaner than it was for the generations beyond and our parents' generations, etc. The measuring also has become ever more detailed. So the fact that we can actually measure PM 2.5 is important, because actually it means we can actually understand the effect that it's having on health. But actually, again, our parents' generation, didn't have the capacity to actually measure these things. It's a bit like river pollution. The fact that we are now measuring pollution in every single river now means that we actually know that they are polluted. The fact is that previous generations never even measured it. So God knows what we were swimming in 50 or 60 years ago. In fact, probably as kids, we actually remember what we were swimming in. But back to you, Dan.
Thank you, Mr. Chairman. The title, Mike, is Zephyrs. And if you would encourage them, because they are finite, they're very, very good equipment, and it would give you a better understanding. The chairman's right that there is new equipment and we're understanding it better. But what the chairman probably hasn't thought, we're not talking of 20 million or 25 million population, we're talking of 60, nearly 70 million people. And the amounts of vehicles from the rivers we used to swim in as young children and felt no ill effect ever isn't available on lots of rivers nowadays, sadly. And the traffic has built up to a phenomenal scale. So it is that. And all I would say, Mike, respectfully, is that if you did encourage them to look at it and look at PM 2.5 and not worry about wood burners and things that are associated, but get down to the core value and look at the main roads and what can be done and how can we work about it. At least you're building an action plan as opposed to just letting it all fly by. Thank you, Mr. Chairman.
Yeah, I think as well, now we're working with health in all policies and we're working with planning authorities and having that input in design, etc. Now, public health are making a difference in design to be able to, for active travel as well as air quality, etc. So even though it's not direct money going in from public health into something to do with air quality, there is a lot of work joining up and trying to get things in place ahead of build out that may make those benefits.
Sorry, just back to air quality, I just forgot the other thing to draw in, I've not put it in the paper, is this funding we've got from the National Institute of Health Research, NIHR, to be a health determinants research collaboration. So there's £5 million worth of funding we've got over 5 years to basically put the local authority, put the council on the same footing as where all the money's gone in public health research before, into academic institutions and the NHS. That will give us a capacity to bid for research funding to undertake to some extent our own research. One of the things that I think got us that bid was talking about sort of changing, air quality in the Leicestershire context, about it not just being about urban traffic, but thinking about the M1, all the different sources I was talking about. So not put in here, but I suppose what else has changed in the last 11 years? By basically putting public health into the local authority, it's opened up those opportunities to then go, actually, this is kind of like our territory. So if we can then bid for money from NIHR to look into these questions in a bit of a different way, then actually that's one of the other things that hopefully we brought in. So I didn't put it in here, but HDRC, I think, is getting into that kind of pushing the boundaries of our knowledge around those wider determinants of health over the next few years.
Thank you.
Excellent. Mike, followed by Gemma.
Yeah, just 3 questions, probably in the budget papers previously, but what's the size of the grant now?
It's 27.5 million.
7.5.
So yeah, so I forget now. Is it 30 something quid? 38 pound per head of population. It's when we came over, it was about 24 million. As I said in the paper, there's about 152 authorities that received the public health grant from the HSC. I think we're the 147th lowest funded per head of population. Derbyshire, for instance, similar kind of population. Their budget is 45 million against our 27 million. Leicester Cities is the same, fractionally bigger than our budget on a population, obviously a third of the size. Nottingham City, if ours is 38, I think last time I looked, it's 110 quid per head of population. So the the comparisons with other places, just like, wish I had their money.
Well, you know, it's all these funding formulas. They don't seem to favour Leicestershire in any respect, do they? There you go.
They don't. Just for good measure, when the grant was set, it was almost kind of more set on historical spend, and because the NHS back in the day, public health was never the place to come to before 2010, 2013, and so when we transferred over, you got what you got given. Right. And because we never had any, they never gave us any, and they've never addressed it by actually changing the funding formula to reflect our needs. But longer story.
Okay, yeah, another time. I'm looking at the dashboard, and you mentioned you do a lot of benchmarking with other authorities. Do they come to us, or do we go to them when there's something green that we're doing well, or they're doing well, and then something red which we're not doing so well? Do we go to them and say, somebody who's got a good green rating on the same issue, whether it's hospital attendance or something else, do we learn from each other?
Right, this is where I'm going to sit back and bring these two in, because that's like an hour's worth of talking about everything we do to push other stuff. So I don't know which one of you want to go first. Shall I go?
In short, yes, we do.
Perfect.
We have
Well done.
We have national sort of commissioners meetings or sort of public health meetings and regional ones, and we all sort of provide case studies of the work we're doing locally, why we're doing what we're doing, any challenges we're having. So lots of that sort of peer-to-peer working as well. So it's not just partnerships locally and internally, it's partnerships across the country as well, and it's with subject matter experts.
Excellent. That's the answer I wanted to hear, because working in isolation achieves nothing. So that was good. My final question is, how much, we've just done the probation part of it, how much of the services we provide are statutory and are non-statutory? You know, looking down the line, what potentially is under threat in the next 2-3 years?
If I go first, it's always a difficult one, because don't forget, we're not funded by the general fund. We are funded by the public health grant, which has to be used, quotes, exclusively on public health activity. How we decide what that's spent on, there is individual statutory services that we need to provide. So comprehensive open access sexual health services, health checks, health visiting. That chews up about 62% of the grant. I'm looking at Adrian, last time we looked. The other 38%, do you call that non-statutory, or do you say, well, actually, the overriding statutory duty is the council needs to take steps, appropriate steps to improve the health of the population. So I could argue everything we spend is statutory. How you determine what you spend that money on to fulfil that overall statutory duty is the bit that then comes into a conversation about, well, actually, what's the areas you need to concentrate on to improve the health and well-being of the population, which would be your big lifestyle drivers like smoking, substance misuse and physical activity, with an expectation in our returns that we give to the Department of Health, and I'll turn to Asia in a moment, that there are a number of categories where they would expect to see a spend of a certain level, because it's outlined really, it's kind of, well, we know what makes a difference to health, so you need to be spending it on this. So it's a complex one. It's not like only spend on your individual statutories and don't spend on this, because if we didn't spend it, we just have to give the money back. And it's all in pursuit of a overarching statutory duty to be a decent public health authority. How we govern this spend, I suppose that's the prioritisation stuff we've spent before. But Adrian, I don't know if you want to give a bit more detail.
Yeah, so just in terms of that, we have to do a return 3 times a year, and then we do a return at the end of the year to say what we spent our money on, and it's very focused in terms of the expectation from OHID as is now, and it has all of those big elements in. So there's children's health in there, smoking, obesity, weight management, health checks, health protection. So it's really rigid in terms of how the expectation is around what we spend our money on, and we're challenged all throughout the year and at the end of the year on any changes that are made during the course of the year. So if we reduce money on obesity, for instance, when we report that through our financial spending returns, we get a question back. So what have you done? Why have you done that, etc. So although we talk about them as in mandated and non-mandated services, there are core services that sit in the legislation that we have to deliver, but everything else is almost prescribed by OHID around what we deliver and what those hard-hitting services are and what we should be spending on them.
If I could just go back to the first part of the question. I know Joshna says yes, but I'd go on, and between us, I can think areas where other places get in touch with us and go, how did you do that? I've got smoking, sexual health, substance misuse, health visiting, homelessness. And then there's other bits for me, safeguarding, clinical governance, any others.
There's probably.
There is. And I do wish, I wished I kept a letter that a high-ranking consultant in respiratory diseases somewhere in the local area wrote to me in 2015. You're nodding your head at this one, where he called for the smoker cessation service, which we were redesigning at the time, to be taken off me and given to the city because we were so bad in going away from the then NHS gold standard. And look what's happened since in terms of smoker cessation service and what we delivered for the money. I wish I'd framed it.
Okay, Betty.
Further on the agenda, but if I am telling me to roll back, I'm really worried about the issue of dying. Well, it's a very difficult time for people and their families and those that are involved, and it shows that we're below national average indicators. I just wonder what more we can do to improve these services. Thank you.
Sorry, just so you know, both the ICB and the Health and Wellbeing Board have done a JSNA, and we've also done development sessions with a wide group of stakeholders. So there's quite a lot of work going on in the background to work out where we are, what is being delivered and what can be done further. So we all want the best for people who are dying.
Bring back to the committee for an update to see where we are, what improvements have been made, etc., and what more we can do. But thank you for that, Louise.
I was going to say, I suspect it's probably not just the public health team. It's probably a sort of a wider issue to do, because I can only speak from personal experience. My father-in-law was in a care home through LCC. Caught COVID, went into hospital, unfortunately ended up passing away within a few days. But I have to say, I think the rest of the family would classify that as actually dying well, because actually he was well treated. Everything that was done for him was done sympathetically and with great support, both for him and also for the family. So, you know, in general classification, would anyone, whilst we're obviously very, very sad to see him pass, would anyone have said that actually his passing was with dignity and was you know, as good as it could have been? I think without a doubt. So, but it was, I mean, it demonstrated, I think, probably the link between LRI, you know, care homes, the way that all of the teams actually reacted and treated him as an individual, but also the family as well. So it would be interesting to see as a combined paper. Jocelyn, you want to say something?
Just to give you some assurance that that's being picked up through the Health and Wellbeing Board. So within public health, we also have a health and wellbeing board manager that's paid through the grant. And she very much leads, does a fantastic job in leading the work of the Health and Wellbeing Board and that partnership development within the strategy. Dying well is one of those strategic priorities, so it is picked up through that. I think also just in terms of a bit more detail on that, I think where we're wanting to go as well is that those earlier conversations, because I think they're very uncomfortable conversations for people to have, thinking it will never happen to me. So I think it's looking at the holistic view. Don't laugh, I know what I've just said. That holistic view of kind of that painting that picture and providing that right support and having those conversations at the right time.
I think as well, we're starting to see numbers going up for people dying at home. And I did have somebody say, I think it was a Health Wellbeing Board, is that because they're not getting the right help? But most people want to die at home. And so that's where people, it's trying to give the person the option they wish. Obviously, it's not able to be done in every circumstance, but yeah.
Gemma, yeah, is the next person. Absolutely. Sorry, Gemma, I apologies. I went to Bessie before you. Apologies.
That's absolutely fine. So it's Hardeep here covering for Gemma because she couldn't make it.
Sorry.
And that's okay, I did scribble. I just wanted to pick up on the partnership point because we have certainly been engaged both through Healthwatch and Voluntary Action Leicestershire through the public health team for the local intelligence that we have, and also when you're looking at commissioning of services and the voluntary community social enterprise sector and the involvement and the gaps in services and the intelligence that we have. And we are strengthening that through some of the work that I'm personally involved with Mrs. Richardson on, so I just wanted to flag that point for you all. Thank you.
Thank you very much, Hardeep. Right, so have we got any other questions? I don't think we have. I was going to ask one last question at the end. You've talked about all the things that people come to us to say, you know, marvellous service, brilliant. You talked about the budget being very difficult and not allowed to mention the election coming up, but just on the off chance that somebody threw another million or so at the public health grant in Leicestershire, is there a particular service or part of the service that we currently do that if you had the resources or you had the ability that actually you think would actually make a significant difference to the health of the population of the county? What's on your wish list?
What's on our wish list? I'll look to my left and right. That's really good. You get so used to not having a wish list. As you what? What do you think?
I guess for me, it would be around continuing to strengthen our community-based services. So those prevention lower tier services that are working directly with individuals make a huge difference to those individuals and inevitably are stopping access to GPs or access to other services in the authority. Those unfortunately are the bits that are hard to measure, but we see it day in, day out, and they are making a big difference.
And then the next bit up, the kind of the lifestyle bit as well, I think would be the other area that we'd love to do more on and build on. But I think it can only happen if we've built up the community delivery element, because it is that next step up.
Well, then around it off, and one from me. Health protection is an interesting one because when it came over, and still is, my statutory duty, our statutory duty as an authority is just to be assured that plans are in place. And yet over the years, you know, what do people think about local authority public health and emails I get? It's measles, it's pertussis, it's obviously COVID. And it does involve us in a deal of response work in a way that was never imagined under the 2013 Lansley reform. So we've kept a response going, one way, shape or form, but actually we squeezed that from the budget. So, you know, if there's one thing that I would want, it would be to sort of recognise that we've got a role in health protection delivery as much as just plan assurance.
Thank you very much. Louise, do you want to add a fourth?
Well, I was just going to say we do have to look at capacity as well, because a lot of we've streamlined so much with budget that we need to make sure that the workforce as well is adequate and not overstretched. But it would be very welcome.
Very much. Right, we'll see whether any pixies around after the 4th of July anyway. Look, thank you very much to Roshna, thank you very much to Joshua, rather, thank you very much to Mike, thank you very much to Adrian. Really interesting to hear your views on how things are, and also, you know, to see the breadth. I mean, it is fascinating to actually see how much is being done by the team here, whether it's through commissioned services or whether it's directly in-house. And I think I echo all the comments from all the committee members that you know, it really is impressive. Louise, I know, has outlined how impressed she is with the team, but I think we can echo that as well. So thank you very much for your input today, and thank you very much for bringing this to us. So
I'd like to thank Gemma as well.
It's not Gemma. Hardin.
Sorry.
You're gonna
And I know,
seriously next time.
and I know Gemma as well because she's my sister-in-law.
You're
Thank you.
forever to be known as Gemma, aren't you?
And as I say, Gemma's virtually my sister-in-law, so I don't know Gemma. But thank you very much for coming, because I think we get Health Watch a little bit of a hard time.
Yeah.
And I'm hoping that Health Watch and that responded to that and get more involved in this, and could work as a good partner with us. Thank you.
Thank you very much.
Oh,
It's
yeah,
dreadful
right.
on name badges, though. You're fired on the name badges.
Okay, that's fine.
Right. Okay. Right. With that note, we better say we're item number 12. Thank you very much for item number 11. Item number 12, which is noting the work programme for the joint HOSC. So the next one of those, 17th of July. Any questions, etc., please put them through Ewan. Item 13, dates of future meetings. Those are set out as on the agenda, so please make a note of those. Item 14, there are no additional items for this meeting, as mentioned earlier, so in which case we are going to close the meeting. So thank you very much to all of those attending today. Thank you. Surviving.